Afternoon, we'll start our satellite symposium, which is sponsored by Lilly. Our speaker is Dr. Kannan Alshammari, consultant adult medical oncology. Dr. Kannan will talk about Ramucirumab efficacy in HCC.
Thank you. Okay, thank you. Thank you, Dr. Ashwaq. Thank you for the introduction. So I was given the task to talk about Ramucirumab efficacy in patients with advanced hepatocellular carcinoma. So these are my disclosures. So the overview of my presentation is going to be the following. So I'll initially talk about Ramucirumab, its mechanism of action. Then I'll move on to talk about background of cirrhosis and HCC and prognosis. Then we'll introduce the Ramucirumab data by talking about the REACH study. Then we'll consolidate this information by talking about REACH-2 study. Then I'm going to present some controversial data talking about efficacy of certain systemic therapeutic agents and their relationship with the etiology of cirrhosis. Then I'll end by talking about patient-reported outcomes in Ramucirumab studies. So Ramucirumab is a VEGF, vascular endothelial growth factor receptor 2 antagonist that inhibits ligand-stimulated activation of receptor 2 ligand, which once it is stimulated, it induces proliferation and migration of human endothelial cells. It is administered intravenously at a dose of 8 milligrams per kilogram every 2 weeks. This is the gastric and hepatocellular carcinoma dosing. Half-life is approximately 14 days. Now, as I have mentioned, Ramucirumab does bind specifically to the VEGF receptor here, blocking its interaction with VEGF-A, VEGF-C, and VEGF-D antigens. Now, this just shows the VEGF receptor 2 and its interaction with other systemic agents, other vascular endothelial growth factor inhibitors. So when we look at the TKIs, you can see that they inhibit downstream signaling. Others inhibit VEGF-A, such as bevacizumab and aflibercept, whereas Ramucirumab does block vascular endothelial receptor 2, and hence inhibiting its interaction with VEGF-A, C, and D. It is FDA indicated in esophagogastric cancers or gastric cancers, advanced or metastatic, either in monotherapy or in combination with paclitaxel after progressing on 5-fluorouracil or platinum-containing chemotherapies. It's also FDA approved in hepatocellular carcinoma with an alpha-fetoprotein of more than 400 after progression on sorafenib or intolerance to sorafenib, and in metastatic colorectal cancer with FOLFIRI in patients who progressed on FOLFOX and bevacizumab. Now, what I want to show here is that high alpha-fetoprotein is a negative prognostic marker. Once it's high, you can see that it's negatively impacting on survival. Patients with advanced HCC with a alpha-fetoprotein of less than 400, they tend to live around historically, around the 10 to 12 month mark, whereas ones with a high baseline alpha-fetoprotein tend to live much less. Now, in advanced HCC patients, approximately more than 1/3 of them will come to you at baseline with an alpha-fetoprotein of more than 400. There are different classifications of hepatoma. One of them talks about your high alpha-fetoprotein being indicative of poor overall survival, being the proliferative subtype of HCC. Patients tend to present with larger tumor, and histologically, they have poorly differentiated histology. These patients tend to do much worse. Another molecular classification, which was presented at ASCO 2019, also defines or subclassifies them into proliferative versus non-proliferative. Your proliferative ones are the ones with poorly differentiated histology, high alpha-fetoprotein, are associated with p53 inactivation, and tend to be associated with your hepatitis B virus. These patients tend to do much worse, as opposed to your non-proliferative ones, where the differentiation is well to moderately differentiated. Their alpha-fetoprotein is not as high as your proliferative class, and perhaps they could be your hepatitis C or your alcohol cirrhotic patients. So as I mentioned before, a baseline of alpha-fetoprotein of more than 400 is definitely associated with poorer prognosis. When you look at the cumulative survival here with time, you can see that ones with over 1,000 tend to do significantly worse, as opposed to ones with alpha-fetoprotein of 400 to 1,000, as opposed to ones with a normal or near normal alpha-fetoprotein, where their survival is the best. So higher baseline alpha-fetoprotein does correlate with increased vascular endothelial growth factor expression. Now, with high alpha-fetoprotein, we expect VEGF-R2 expression to be higher. Once we actually silence alpha-fetoprotein, expression of VEGF2 is lower. Now, how does this impact on survival? We know that high alpha-fetoprotein patients tend to do worse, and this is proportional with high VEGF-R2 expression in human HCC, and it is associated with the aggressive phenotype and hence less survival. We can see here on the right-hand side, the survival Kaplan-Meier curve, showing that patients with a higher expression of VEGF-R2 tend to live less. Preclinical studies have shown that once we block VEGF-R2, that we reduce angiogenesis. Preclinical studies, so basically tumor xenograft models, have shown that once we have high alpha-fetoprotein HCC models, xenograft models or cell lines, they are sensitive to VEGF-R2 inhibition and tend to do better once they're given these agents. Now, REACH study basically has shown that patients with an alpha-fetoprotein of more than 400 nanograms per milliliter, once given Ramucirumab after progression or intolerance to sorafenib, tend to do better. Now, this Kaplan-Meier curve shows patients in REACH 1 that have a higher alpha-fetoprotein, so an alpha-fetoprotein of more than 400. Now, this was a pre-specified subgroup analysis. Now, just to remind everyone that REACH 1 took all comers with advanced HCC, regardless of high alpha-fetoprotein or lower alpha-fetoprotein. However, a pre-specified subgroup analysis showed that patients who were exposed to Ramucirumab and have a high alpha-fetoprotein, these patients tend to have an improvement in overall survival. And we can see their overall survival is 7.8 months, as opposed to almost half of it, 4.2 months. And this was a robust hazard ratio of 0.67 and a statistically significant p-value. Now, phase 3 REACH has basically shown that we have a benefit in overall survival, as I mentioned before, with a higher alpha-fetoprotein. Now, when we take patients whose alpha-fetoproteins are less than 400, we can see in the Kaplan-Meier curves here that they tend to cross each other. So there is not a significant benefit in overall survival in this subgroup. And now this is also, this shows that the overall survival benefit in the subgroup that have an alpha-fetoprotein of more than 400 in REACH 1, these patients, the different categories tended to do better. So the overall survival benefit was consistent across different subgroups. So age, etiology of liver disease, and we'll focus on that in the next few slides. Performance status and BCLC trial or BCLC scores of B and C. Now, when we think about adverse events in VEGF inhibitors, we always think about hypertension and bleeding. And this is expected to happen in patients who get exposed to VEGF inhibitors. So about 12% experienced treatment-related adverse event of hypertension, which was controllable. So when we think about the relationship between a baseline alpha-fetoprotein and the expected overall survival and the expected reduction in hazard ratio, it was found to be inversely proportional, meaning if your baseline alpha-fetoprotein was high, your hazard ratio is expected to be lower, indicating better benefit with ramucirumab therapy. In summary, patients with higher baseline alpha-fetoprotein of more than 400, I have shown to you that it's a negative prognostic marker in advanced HCC. VEGFR2 and VEGF are signaling pathways that promote tumor angiogenesis and promote metastasis in HCC. There are certain subtypes with high alpha-fetoprotein in HCC that basically show increased angiogenic activity. Cell lines that were given VEGFR2 inhibition did better if the alpha-fetoprotein was high. In REACH1 phase 3 study, overall survival and progression-free survival benefit was statistically significant and clinically meaningful in patients whose alpha-fetoproteins were more than 400. Single-agent ramucirumab showed a predictable safety and tolerability profile, and hence this phase 3 study basically led to REACH2, which is a phase 3 study that randomized patients with a biomarker, so only patients with a alpha-fetoprotein of more than 400, to basically enrich the potential of response to ramucirumab. So REACH2 basically included patients only with alpha-fetoprotein of more than 400. They had to have a child PUA. They had to have advanced HCC and progressed or were intolerant to sorafenib. They were randomized 2-to-1 randomization to ramucirumab versus placebo, and primary endpoint was overall survival. Now, I think I mentioned this before, so I'm going to skip this slide. Baseline characteristics were comparable between the two groups in terms of most of them being BCLC, so these are advanced patients. A significant proportion of them were child PUA5, a variety of etiologies of liver disease, and this is quite important. Patients who progressed were significantly less in the ramucirumab group as opposed to the placebo group, so 65 as opposed to 81%. Now, when we look at overall survival in REACH2, it was found to be 8.5 months as opposed to 7.3 months in the placebo group. Hazard ratio was decent at 0.71 with a statistically significant p-value of 0.02. Now, when we pool REACH1 and REACH2, now REACH1, only the patients whose alpha-fetoproteins were more than 400, you can still see a statistically significant and clinically meaningful overall survival benefit with a robust hazard ratio of 0.69, meaning that almost 30% will improve. Progression-free survival was also significant and almost double, so 1.6 months as opposed to almost 3 months with ramucirumab. In terms of clinical responses, disease control rate, so this is combining your CRs, your partial responders, and stable disease, were significantly higher as opposed to placebo. So almost 60% as opposed to 40% in placebo. Commonest adverse events, as expected with VEGF inhibitors, we expect hypertension to happen, a small number with fatigue, and some peripheral edema and proteinuria. Adverse events of special interest. So 25% of patients experienced hypertension of any grade. 25% also experienced some bleeding events. Now, this is expected with VEGF inhibitors. 1/5 of patients experienced some degree of proteinuria, and you can see the rest of the adverse events here. So in conclusion, ramucirumab did induce a survival benefit as opposed to placebo in patients with HCC and whose baseline alpha-fetoprotein was high, who progressed or did not tolerate sorafenib. It did reduce the risk of death by about 30% or progression or death by 55%. It significantly improved your disease control rate. It was about 60%. Now, it is well tolerated with no unexpected toxicities. The investigators concluded that ramucirumab did show a meaningful survival benefit in a biomarker-selected HCC patient population. So the biomarker was alpha-fetoprotein being more than 400, that we know is associated with poorer prognosis. Now, this is where some of the controversy happens, and I would like to hear the opinions of our experts here, Dr. Ashwaq and Dr. Fahad, when they talk about their slides later. So, etiology of cirrhosis perhaps does affect response. There is an emerging evidence that the etiology of cirrhosis does impact on response to certain systemic therapies. Immunotherapy, and based on this meta-analysis, was not as efficacious once the etiology was NASH, as opposed to Hep B or Hep C. Now, conclusions from this meta-analysis was that NAFLD and NASH were independently associated with shortened survival if they were given PD-1 inhibition. Now, a very recent publication, in fact, it was published just last month, 26th of June, basically looked at this question specifically, looking at etiology of HCC and Ramucirumab efficacy. And to cut a long story short, Ramucirumab did improve overall survival in all subgroups. Now, all subgroups being your Hep B, Hep C, and other, including NASH and NAFLD patients. Now, what is ALB score? So albumin bilirubin grading or scoring system is derived from a validated nomogram that objectively assesses prognosis in liver patients with HCC. It could be a better prognostic indicator of mortality, given its simplicity, and could substitute child score, MELD, or MELD sodium scores. Now, Ramucirumab in REACH-1 and REACH-2, now this was published just last year, the investigators concluded that Ramucirumab did not worsen your ALB grade. So it did not cause decompensation of liver disease when compared to placebo. Now, Ramucirumab improved the overall survival in patients with ALB grade 1 and ALB grade 2. And this was statistically significant and clinically meaningful. Now, moving on to the last part of this presentation, which we will talk about patient-reported outcomes across REACH-1 and REACH-2. So what are PROs? So they're measures used in clinical trials to capture aspects of patients' health reported directly by the patient without introducing bias from third parties or us as physicians. They are distinct from the physical toxicities that are reported by clinicians or nurses and are collected using standardized instruments or questionnaires at different time points in the therapeutic pathway. Why are they important? Because they're subjective. They are a reflection of how the patient feels, their functional status, their symptom burden, and their patient or the patient experience. They are relevant specifically in cancer because in many certain instances, quality of life is perhaps more meaningful in patients than longevity, than their age or their longevity. Now, why are PROs and health-related quality of life assessments important? Certain studies suggested that we should incorporate those in routine oncologic care. A meta-analysis, despite being old, looked at 30 randomized controlled trials and basically showed that quality of life, health-related quality of life indicators are prognostic of survival. PROs were shown also to be at the same study actually, to be an independent predictor of overall survival and in certain cases to treatment response. The benefits of PROs is they increase patient-physician communication. They basically improve our ability to manage symptoms because they tend to report these symptoms more. Now, this was recognized by the US FDA as a clinically relevant measure for cancer therapy approvals. Now, this recognition by the US FDA basically led to an increase in the use of patient-reported outcomes in clinical trials to up to 30% in 2013. So we know that HCC patients, when they present at a later stage and their prognosis is poor, they have limited therapeutic options. Now, patients with HCC, specifically ones who have cirrhosis, definitely have significant morbidity. Their symptoms represent a substantial physiological and psychological burden on them, and definitely will affect their quality of life. Now, Ramucirumab, as I've shown you before, did improve overall survival, patient-free survival in REACH 1 and REACH 2. I want to present to you some patient-reported quality of life outcomes in patients who were given Ramucirumab. So 2 instruments were administered during REACH 1 and REACH 2. One of them is the FACT Hepatobiliary Symptom Index 8, and the other one was the European Quality of Life 5-dimension instrument. Now, the FACT Hepatobiliary Symptom Index is a self-administered questionnaire that assesses the most frequent and concerning symptoms experienced by patients with cirrhosis and HCC, basically fatigue, nausea, pain, back pain, jaundice, and others. Now, when we look at this here, most of these 8 dimensions or 8 symptoms were actually not worsened when patients were given Ramucirumab as opposed to placebo. In fact, time to deterioration was significantly less. Hazard ratios were quite significant, and I'm going to mention which ones did have a major impact. So time to deterioration in disease symptoms measured by the FACT Hepatobiliary Symptom Index was significantly delayed in patients given Ramucirumab as opposed to placebo. Now, differences in time to deterioration, specifically for back pain and weight loss, were observed, and delay in deterioration of these symptoms extended the previously known benefit of survival. In the pooled population of patients with alpha-fetoprotein of more than 400, now this is, I think in REACH 1, their time to deterioration in the FACT Hepatobiliary Symptom Index score was prolonged with Ramucirumab as opposed to placebo. Hazard ratio of 0.72 and significant p-value, including significant differences in back pain, weight loss, and pain, and all of these were statistically significant. Now, the European Quality of Life 5-dimension score was not statistically significant different between Ramucirumab and placebo groups. And results in the individual trials were consistent with these findings. So in conclusion, Ramucirumab in the second-line setting in advanced HCC patients demonstrated a benefit in delaying deterioration of disease-related outcomes or symptoms without worsening health-related quality of life measures. In patients with alpha-fetoprotein of more than 400, the significant survival benefit observed in those patients treated with Ramucirumab was coupled with a trend in patient-focused outcome benefits. And by that, I conclude. Thank you. Sure. You want me to?
We don't have time. Thank you, Dr. Kannan, and thank you, Lily, for sponsoring this. So we'll move to the next session. So I'll introduce our moderator, Dr. Ahmed Al-Shahri, Consultant Medical Oncology as National Guard Jeddah, and Dr. Abdullah Shurm, Director of the Cancer Center on King Fahd Medical City.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Ashwaq, for introducing me and for